So now we'll be proceeding with Dr. Suresh, who is currently professor of radiology at the University of Illinois and University of Louisville. And he is the past president of the American Society of Head and Neck Radiology. So Dr. Suresh will be giving us a talk about tumors of oral cavity and oropharynx.
Thank you very much for coming. I think for the next 40 minutes, I know we're right to lunch. I'll try to cut my talk down a little bit. Well, still be comprehensive. What we're going to talk about is squamous cell carcinoma of the oral cavity and the oropharynx. Now, Dr. Yosera gave me a bunch of, don't go away, don't run away, okay? All right? Don't run away. She gave me some difficult talks, but when I talked to her about, by the way, you should be proud of your mom, okay? I love your mom, she's great. She gave me some difficult talks, but on this one, when we talked about this specific topic, I'm going to be focusing on squamous cell carcinoma. So what I don't want to do is just give you a laundry list of different tumors that can involve the oral cavity and the oropharynx. I think you can go to any website and figure that out. But really what I want to do is to sort of give you a practical approach on squamous cell carcinoma predominantly, and also try to give you a sense of what your surgeons and your clinicians need to know. So one of my unusual jobs is every Wednesday afternoon I actually see patients. So I actually examine patients, then we go and look at the imaging studies, and then we work with our surgeons to figure out exactly where to make our cuts. So every patient that we see, we discuss where to perform the surgery, what type of flaps to use, and so on and so forth. So hopefully what I'll do is I can take a little bit from my experience and maybe share that with you, and then if you have any questions afterwards, we can chit-chat over a Diet Coke or something like that. So this talk is going to be aligned very nicely with Dr. Wiles. I kind of flipped it around. I'm going to talk to oropharynx first and then the oral cavity. So as he very elegantly stated, the tongue base is that area of the tongue that's located behind this area, which is a chevron-shaped area, which is the circumvallate papilla. So everything posterior to this is in the tongue base. So when we have tumors that are involving the tongue base, we can have these various patterns. And again, the patients, the doctors, and I can throw myself as a doctor in there too, we can see the squamous cell carcinoma involving the tongue base. You know, if your report says tongue-based cancer, well, that's good, but we can see that. But what we need to know from a clinical standpoint is that if you do have a tumor right here which is involving the tongue base, and this is squamous cell carcinoma, the way the surgeons and the radiation oncologists, and especially you, the patient, has to try to figure out is, do I want to be treated with surgery, do I want to be treated with radiation therapy, or do I want to be treated with chemo and radiation therapy? Those are the real decisions that we have to make. So in this particular case, we can nicely see this tumor that's involving the tongue base. So one question that I always get asked is that if you have a tumor like this, how do you know what part's in the tongue base and where's the floor of the mouth? So as Dr. Weil mentioned, if you look at these paired muscles right here that go for the genial tubercle posteriorly, you can see that they're vertically oriented. They sort of look like stripes. And you'll see my favorite animal is the tiger, so we're going to be talking about tiger stripes later. But these look like tiger stripes running from anterior to posterior. But as we go more posteriorly, we can see that now the fibers are a little bit more transverse. So that's the junction between the floor of the mouth and the area that we're talking now, which is the tongue base. So in this particular lesion, this tumor is involving the tongue base, and here's our fat in the lingual septum. We can see that that tumor extends to the lingual septum. So this is a pretty non-specific appearance, but 9 times out of 10, this is going to be squamous cell carcinoma involving the tongue base. So you've made the diagnosis of squamous cell carcinoma involving the tongue base. Some of the pertinent things that you have to identify, particularly, does it cross the midline and does it extend deeply to involve the floor of the mouth? Those are 2 particular areas that if you include your report, as you'll see in a couple of slides, you will dramatically change how those patients are treated. So it's not just there's a tongue-based cancer, but what are the specific spread patterns? So these are the classic imaging findings. This is squamous cell carcinoma on CT. This is it on MR. I can't tell the difference. You know, as you'll see in a couple of slides, other tumors involving this area can just look like this, but just by playing the statistics, we know it's squamous cell. Now, this I really want to highlight. Does everyone see this mass right here? This is a metastatic lymph node involving the neck. Now, please, 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 I'm begging you, okay? Inshallah, I'm begging you, please. is that if you see a cystic mass in the neck in an adult, do not call that a branchial cleft cyst. If you call that a branchial cleft cyst, I will come find you, and I will do whatever. I can't say. I have 3 more days in Kuwait. I don't want to get kicked out, okay? But I will find you, because this mass involving the left side of the neck, if it's low attenuation, is metastatic squamous cell carcinoma until proven otherwise. If you are young meaning 16, 12, 13, and then you see a cystic mass that's purely cystic and with a thin rim, then you can call it a branchial cleft cyst. But in an adult, okay, in an older patient, what's old? 5 years older than me, okay? In that type of patient, then you have to say it's a metastatic lymph node. So please don't do that, because I still see this missed, okay? So as we know, one of my other jobs is I've been on the radiologist on the AJCC staging committee. So I think you know we stage cancer. So I've been on that committee for the last 20 years. And in the last edition, we identified a new type of tumor, which is HPV positive oropharyngeal carcinoma. And this HPV positive, as we know, predominantly involves the tonsil and the tongue base. Now, this is a sexually transmitted disease. So in the United States, about 80 to 90% of all oropharynx cancers are HPV positive. The good thing is that they have an overall better prognosis. So they can be resistant, they can be more sensitive to chemotherapy and radiation therapy. Now, HPV negative tumors, as we'll see later, can still occur in the oropharynx. They're probably more prevalent in areas, if you will, that are a little bit more conservative, like the Middle East, like in Indonesia, et cetera. And so you still can have HPV negative oropharynx cancers, but it's going to differ based on the region of the world where you live in. Now, when we talk about oral cavity cancers later, then yes, the majority of these are going to be HPV negative. But for oropharynx cancers, especially in Europe and the United States, they're going to be HPV positive. So the reason why I mention this is that if you have an HPV positive oropharynx cancers, the surgeons and the radiation oncologists have to come to a decision as who is best to treat these patients. Because the surgeons can take it out, and the radiation oncologists and the chemotherapy doctors know that they can also cure this cancer. But this is where we play a major difference in radiology. So again, if you just say it's a tongue-based cancer, the surgeons are going to say, well, it's probably HPV positive. But what's the information that we can provide on our report that's going to determine whether or not these patients are going to be treated with surgery, such as transoral robotic surgery, or to be treated with radiation or chemotherapy? So the things that I like to include in my report is there deep invasion? I showed an example of deep invasion of a tongue-based cancer that extended into the floor of the mouth. Does it cross the midline? Is there involvement of the parapharyngeal space? Are there unresectable lymph nodes? Is there any bone invasion? Are there retropharyngeal lymph node metastases, retropharyngeal carotids, proximity to the carotid artery, and prevertebral space invasion? So if you want to take a picture of this. Now, those of you that are coming to my workshop tomorrow in oncology, we're going to go over all these things in great detail. You know, if I went over in detail right now, I'll be talking until dinner time, and we don't want to do that. But this is the checklist, if you will, that I like to include in my reports. Now, when we look at other tumors that could involve the tongue base, realize that there are other small types of tissue. We heard a beautiful lecture again by Dr. Weil, excellent job this morning again, where you had salivary gland tumors. If you take those same pieces of salivary gland tissue and you put it in areas where they should not be, and those areas where they should not be are things like in the tongue base, which there is a relatively high proportion, then you can have the same type of tumors involving the parotid gland that all of a sudden end up occurring in the tongue base. And that's what we call, quote unquote, minor salivary gland tumors. It's the same salivary gland tumors, but somehow it arises in these little rests of tissue that get lost in other parts of your body. So these are examples of adenoid cystic carcinoma, and this is an example of a polymorphous adenocarcinoma. There is no way for me that I can tell the difference. The only thing that we can suggest is that when I see a patient and I see that they have a tongue-based mass and I don't see a mucosal lesion, everything is below the mucosa, then I can suggest that maybe it's a minor salivary gland tumor. But radiologically, it's very, very hard to be accurate. So the next part of the oropharynx is going to be the tonsil. Again, Dr. Weil did a beautiful job going over the tonsil. He talked about the three components, which is the main component here, which is the palatine or the fascial tonsil. We then have this muscle that he mentioned, the palaeoglossus muscle, which forms the anterior tonsillar pillar, and there's another muscle posteriorly, which is the posterior tonsillar pillar. 80 to 90% of all squamous cell carcinomas that involve the tonsil are going to arise from the palatine tonsil. So 80 to 90% of those. Occasionally, we will have tumors involving the anterior tonsillar pillar and tumors that involve the posterior tonsillar pillar. But really, just for the sake of time, we're going to concentrate on that specific area that you'll see most commonly in your practice. So this is what I will see. I'll go in there and examine the patient, and I can see that they have a squamous cell carcinoma involving the tonsil. Do I need a radiologist to tell me there's a squamous cell carcinoma involving the tonsil? No, not really. But where I really need the radiologist, i.e. myself, what my surgeons rely on me, is when they see a tumor involving the tonsil, they again have to determine, is this a patient that I can treat with surgery? Or should this patient be treated with chemotherapy and radiation therapy? This is where we really add value. You may have heard value in radiology. You know, the real value in radiology is what can we include in our report that's going to change directly how that patient's treated. So if I see a patient like this that has a cancer involving the left tonsil, notice that this cancer is extending into the oropharynx. There's no deep extension. So this is a very nice case where the surgeon can do a tonsillectomy or transoral robotic surgery, and they're done. Now, what I do in our tumor board is this is another patient that has a tonsillar cancer. But look at the difference here. If you just said there's a tonsil cancer, well, I can see that. But on the other hand, look what we could do. Draw a line down the middle, compare the right side to the left side. Okay, this is what I do every day in my practice. So if you want to do a fellowship with me, you're going to hear this 1,000 times, okay? Draw a line down the middle, compare the right side to the left side. Now, what do you call the space that's next to the pharynx? Well, that's the parapharyngeal space. Look at the left side. Notice how the parapharyngeal space is gone. If you look closely, what's this muscle right here? This is the medial pterygoid muscle. Notice how this tumor is abutting the medial pterygoid muscle. If you look anteriorly, look at my nice tiger stripes. I've got gray, I've got black, I've got gray, I've got black, I've got gray. Look on the opposite side. This is all completely obliterated. All this tumor is extending anteriorly. So both of these have tonsillar carcinomas, but the things that I include in my report in this case is that I will tell the surgeon there's a left tonsillar carcinoma, there's deep extension into the parapharyngeal space, it's indistinguishable from the medial pterygoid muscle, and it's growing anteriorly such that it's abutting the posterior aspect of that mylohyoid muscle. I'm not telling him which way to treat it, but that's the information that I can include. Now, a dirty little secret is sometimes I've been around the game long enough, if I see a patient that I feel that they should be treated some way, sometimes I'll embellish in my report and emphasize those things more than I should, because I know deep in my mind that if I put those things in there, I'm actually going to direct how these patients are treated. So don't put that on the recording, okay? Don't record that, okay? So the next area that we'll talk about is a soft palate. And again, as Dr. Weil mentioned, the soft palate is that structure which is located posterior to the hard palate. It just kind of sinks down here, flops down here, and there's the uvula. So when I think of the soft palate, I think of the palatal arch. So when we look at the palatal arch, we have this palatal arch, and we have these two muscles. And these two muscles are the Italian muscles. And they're the tensor veli palatini and the levator veli palatini. Does anybody remember those in medical school? How many of you radiologists went to medical school? I got 3, all right. And nobody remembers the tensor and levator veli palatini. That's okay. But the way that I think of the soft palate is that when I look at this arch right here, I see one arch here, I see another arch here. These are what we call the tonsillar pillars, which we just talked about. But what communicates one tonsillar pillar to the other? Well, it's the palatal arch. So for me, it looks like an Italian arch. Now, what tethers the palatal arch to the skull base? Well, those two tethers are the tensor and the levator veli palatini muscles. So when I think of the palatal arch, this is how I think about the soft palate. So when we look at the soft palate, here's a classic schematic illustration of a tumor involved in the soft palate. Now, one thing about the soft palate, and I'll emphasize to you because this is my third trip to Kuwait, and I know how smart you all, and I also know the resources that you have, and I know you have great equipment, okay? That's undeniable. And for me, coming to Kuwait over the last 20 years, it still amazes me the talent that we have here. Now, what we have to be able to do is that once you have this great equipment, just realize that you always have to reconstruct your CTs in the sagittal plane. Because if you're looking at a CT scan in the axial plane, this is actually a patient with the soft palate cancer. It's really hard to see because our eyes look for symmetry one side to the other, and you could potentially blow right past that. But in situations like this, remember to look at the sagittal images, and you'll be able to see this large soft palate cancer. So as I mentioned before, the decision is going to be if the surgeon sees a patient like this that has a soft palate cancer, should I treat with chemotherapy, radiation therapy, or surgery? If it's a little soft palate cancer, the surgeons can go in and cut it out. But on the other hand, remember what I talked about the soft palate, how it's connected to the skull base, and they have those two primary muscles. Well, what do tumors love? Tumors love smokers and drinkers. Tumors love nerves. And tumors love muscles. That's what tumors love. Now, as I mentioned before, what's above the soft palate? We have the nasopharynx. So draw a line down the middle, compare one side to the other. If you look at the right side, this is the torus tubarius. This is the opening of the eustachian tube, and this is the famous fossa of Rosemuller. So if you look from the right side to the left side, you see where the yellow arrow is pointing at? That looks thickened, right? Anytime that I start seeing a thickened torus tubarius, what I'm worried about is superior spread of tumor from the soft palate. And when we look at this contrast-enhanced T1 weighted images, can I convince you by the yellow arrow there's too much enhancement on the left than compared to the right? Dr. Yosra, can I convince you? Yes? So that's actually tumor that's growing up along another muscle which actually forms along the torus tubarius, and it starts with an S. Anybody remember that one? I'll fly you to Indianapolis to visit me if you remember that muscle. In the middle of winter. No. It's called the salpingopharyngeus muscle. So this is the salpingopharyngeus muscle, that tumor is growing superiorly. So why do I mention that? Well, first of all, it's something we learned in medical school. Secondly, if you say there's cephalad spread, then these patients are going to be treated with chemotherapy and radiation therapy because in most institutions, tumors that involve the nasopharynx from the soft palate are not going to be treated with surgery. So that's how we really make a difference. That's how we can really direct how these patients are treated. Now, there are other tumors that can involve the oropharynx. Again, I really can't tell the difference. If you are immunocompromised, this is an example of Kaposi's sarcoma. If you're a child, as we heard before, under the age of 16, the most common solid tumor to involve a child is going to be rhabdomyosarcoma. And in the United States, this is probably going to be non-Hodgkin's lymphoma. But this was given to me by my friends in Tanzania. Every week I read out with the oncology program in Dar es Salaam. And this is an example of Burkitt's lymphoma, because Burkitt's lymphoma is endemic in sub-Saharan Africa. So I can't tell the exact type of lymphoma it is, but based on the location geographically, then we can suggest that this is Burkitt's lymphoma, and this did turn out to be Burkitt's. So we talked about the oropharynx. Can you take a nice picture of me here? Get my best side. It's this side. It's this side. Right there. Can you just get rid of my bald spot? That would be good. Only one. Okay. All right. So now we'll go ahead and turn our attention to the oral cavity. So Dr. Weil, again, did just an absolute wonderful job talking about the buccal region, where he talked about the gingivobuccal sulcus. So in the United States, the most common cause of a buccal cancer is going to be snuff dipping. So you take tobacco and you put it between your cheek and your jaw. Now, Dr. Shroff and I know that being from India, we know the other common cause of buccal cancer, and that's betel nut. So this is the classical example of a betel nut. So the challenge is, as Dr. Weil said, you have a mucosal lining involving the gingiva, and then you have a mucosal lining involving the buccal area, which is the lip. Now, surgically, if it comes into my clinic, I know where the cancer is. But radiologically, all we end up seeing is this mass right here. So how do we distinguish whether it's involved in the lip or the gingiva? Well, as he mentioned, you do the puff cheeks technique. So in this case, what we see here is this tumor that's involved with the anterior portion of the lip. So this is actually involving the buccal region. And in this case is another tumor involved with the buccal region. So even when I was here, I got a phone call in the middle of the night here saying, I've got a patient that's got a gingival buccal cancer. What do I do? And I said, number one, don't call me when I'm in, Kuwait, but that's okay. But we did actually say, get a CT scan and do something with a puff cheeks technique. And that'll help separate out whether it's from the lip or from the gingiva. So why is that actually important? The reason that's important, because if there is a low volume lesion that's just involved in the lip, well, the surgeons can do a wide local excision. But on the other hand, if there is a lesion that's involving the gingiva buccal sulcus, and it's arising from the buccal cortex of the mandible, and there's bone erosion, then these patients are going to have part of their mandible resected, and that's called a segmental mandibulectomy. Now, I think tomorrow I'm going to give you a talk on flaps and grafts and things like that, so I won't show you the red meat pictures, if you will. Those will all be for tomorrow. But suffice it to say that once the patient undergoes a segmental mandibulectomy, which is predicated on what we say in radiology, if I said there was no bone erosion, that they're going to have a wide local excision. But if I say that their bone's eroded, the mandible's in the pan. And now you've just said to that patient, you're going to have a 6-hour procedure based on what you see on your report. And then tomorrow we'll go over the types of flaps and grafts. So please, 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 don't underestimate the importance that you have in these patients. So the next area is going to be the oral tongue. So as we mentioned before, this was our circumvallate papilla, and then everything anterior to the circumvallate papilla can either be called the oral tongue or the mobile tongue. There are various ways that you can refer to that. Now, what I will do really quickly is to talk about the staging system for oral cavity cancers, because it's different if it's HPV negative. So, as I mentioned, being on the staging committee in the 8th edition, we introduced this new staging system. And so a T1 lesion is if there's a tumor less than 2 centimeters or less than 5 millimeters in depth. Now, all of you all here love head and neck radiology, right? Right? Can I feel the love? You wouldn't be here, right, listening to me. You'd be out there eating some shisha or something like that, right? So, but the point is that you smoke shisha. Oh, yeah, what's that? Yeah, you smoke shisha. I made a mistake. I was going to say shish kebab, but then, I just smoking. It's probably the shisha I smoked last night. But so one thing that I want to emphasize is that, as you'll see, is that when you start looking at tumors involving the oral cavity, and especially the oral tongue, you're going to measure the tumor. You're going to measure it in a diameter, an anterior-posterior diameter and a cross-sectional diameter. That width of the tumor is not depth of invasion. It's not depth of invasion. That is a width. The depth of invasion is a histologic diagnosis where you look at the basement membrane, and then what the pathologist does is they approximate the basement membrane, and they look how deep that tumor is. And if that depth of tumor is less than 5 millimeters, then that is a superficial lesion. But as that depth grows more and more and more, then this upstages the lesion. But as we start looking at these tumors, for instance, this right here, this is a lateralized lesion that's involving the oral tongue. This width right here is tumor width. It's not depth of invasion. So if you start calling this depth of invasion, then all of your tumors are going to be T4 lesions. So please don't do that. So the nice thing here is that if we have a lateralized lesion, it doesn't cross the midline. Obviously, these tumors tend not to erode the bone. Then the surgeons can do a nice wide local excision and the patient's out of your office. But on the other hand, if you say that these tumors cross the midline in the oral tongue, it's deeply invasive, as we see here, then the surgeons are going to have a discussion with the patients, because remember, these are HPV negative, so they're not going to be responsive to chemo and radiation therapy. So the surgeons may still try to maybe send the patients for chemoradiation therapy, but the other option is to do a total glossectomy. And if you do a total glossectomy, you have to remove the larynx, otherwise you're going to aspirate. So it's this type of size and this type of depth invasion does it cross the midline. This is where we really, really make a difference. So the next area that we'll talk about is the floor of the mouth or the sublingual space. And I do use those terms interchangeably. As Dr. Weil said, is that this area that's below the tongue is going to be the sublingual space of the floor of the mouth. Now, where we get into a little bit of problem is that in the head and neck, we're pretty smart people. You know why? Because we like to give talks, right? And so we give these talks, but we love to confuse you. So head and neck, we take the same piece of anatomy and we give it different names. So the first time you invited me here, I probably talked about the sublingual space. The next time you invited me here, I talked about the floor of the mouth. So I confused you. So you had to invite me back a third time, right? So it's the same way when we talk about the floor of the mouth or the sublingual space. Because sublingua is lingual for what? Anybody? Anybody take classics? Latin for tongue, right? Okay, but what are the muscles that Dr. Weil talked about? He talked about the genioglossus muscle, right? He talked about the hyoglossus muscle, right? Well, what's Greek for tongue? What does glossus mean? Glossus is Greek for tongue. So the point is, when you talk about the tongue, you actually flip our Latin roots. So the tongue is either lingua or glossus, and even in the floor of the mouth and the oral cavity, we flip the roots, so it can be really, really confusing. So this area that's below the tongue can either be the floor of the mouth or it can be the sublingual space. So we talked about the upper margin right here, which is the mandible. This is the myeloid line. This muscle right here is the mylohyoid muscle. And this is the hyoid bone. So the reason it's a mylohyoid muscle, because it goes from the myeloid line to the hyoid bone. So when we talk about the anatomy, he talked about the lingual nerve, the hypoglossal nerve, and then the lingual artery. So when I think of the floor of the mouth or the sublingual space, I think of a teacup. So the rim of the teacup is formed by the mandible. The wall of the teacup here is formed by the mylohyoid muscle, and the base of the teacup is formed by the hyoid bone. So basically, everything in that teacup is located in the sublingual space. So this is what we see schematically. This is what we see when you look in someone's mouth. This is an ulcero-infiltrative lesion. So again, I don't need to spend a CT, the money for a CT or an MR to be told it's a cancer. What I want to know is that if I see this patient, how do I treat them? Can they be treated with a wide local excision? Can they be treated with a segmental mandibulectomy? Is there other options? So this is an example here of a patient that has a floor mouth carcinoma. Now, where is this cancer? So what I do is I draw a line down the middle, compare the right side to the left side. Now what I want to do is look for symmetry. I look for my tiger stripes. So there's a white stripe here, a gray stripe here, a black stripe here, and then I see a very, very white stripe here, and then another stripe here. Everybody see those stripes? Yes? No? Maybe? If you smoke some shisha like I do, you'll be able to see those stripes. But on the opposite side, notice how those stripes are completely gone. And what you see here is this mass right here, which is completely obliterating the stripes. So what I would say in this case is I would measure this floor mouth carcinoma, talk about the width of it, and does it cross the midline, and as it doesn't. But more importantly, there's no bone erosion. So this is a tumor that can be treated with an intraoral approach. But in this particular case, it's another example. Notice how my tiger stripes are gone. And then when I look at the bone, there's erosion of the lingual cortex. In fact, that bone is sclerotic. This patient would require a segmental mandibulectomy. So when you have your segmental mandibulectomy, then you have to reconstruct these procedures. And again, we'll talk more about this. But it's kind of a nasty picture to look at right before lunch. But in your report, by saying there's bone erosion, you're the one that determines how this patients are treated. No matter what the surgeons say, if it's in your report, the surgeon's obligated to take out the mandible. So when we talk about the value and the real importance of what we do, that's what we do. Now, there are some other tumors that can involve the floor of the mouth. Again, you can have the minor salivary gland tumors. As I mentioned before, they're little pieces of salivary gland tissues that get lost. You can have tumors that are of neurogenic origin. Why? Because you have those two nerves. You've got the lingual nerve, you've got the hypoglossal nerve, so tumors can arise there. I can't tell the difference. I actually thought this was going to be squamous cell carcinoma, and it turned out to be a neurofibroma. On the other hand, I saw another case that looked just like this that I thought was going to be neurofibroma. It turned out to be squamous cell carcinoma. So it's really, really hard to separate it. But this one I did get right. This was a patient, a 23-year-old, that had a rapidly enlarging tongue. And when you look at this, this is mostly fatty. And this turned out to be a liposarcoma. So occasionally you can make the right diagnosis, but again, it's a little bit hard to do. So the last two things that we're going to talk about are, number one, the retromolar trigone. Now, again, Dr. Weil did a beautiful job talking about the retromolar trigone. The only thing that I can add to this is that there are different ways to classify the teeth. You can number the teeth. You can give numbers to the teeth. The thing is that when I'm in my tumor clinic, we've got a bunch of dentists, and they always number the teeth. But the US system numbers the teeth differently than the international system, and I just can't remember that, so I just name the teeth. So if I name the teeth, this is the central incisor, this is the lateral incisor, this is the canine, first premolar, second premolar, first molar, second molar, third molar. So what do you call the space that's behind the third molar? Well, that's the retromolar trigone. Now, how many of you have had your wisdom teeth out? So I want to congratulate you because you have the largest retromolar trigones in this room. I know you've wanted to be the best at something, the best and the biggest at something, and congratulations, you get the award for the largest retromolar trigones. I hope you'll be proud of that. So this is an example here of a patient that had both of the wisdom teeth out, and these are the expansion of the retromolar trigones. And again, Dr. Weil did a beautiful job talking about this area right here, which is the pterygomandibular raphe. We have the buccinator muscle and the superior constrictor muscle. Why do I mention this in particularly? Because if I have a 3-centimeter tumor involving the oral tongue, well, that tumor is going to grow from right to left, anterior to posterior. But look at this area where the retromolar trigone is. It's right behind the maxillary tuberosity, and it's just anterior to the ramus of the mandible. So if I take that 3-centimeter tumor and I stick it right here, that tumor is going to go laterally, it's going to grow medially, but look what it's going to bump into right here. It's going to bump into the mandible. So the point is that when you have retromolar trigone carcinomas, it's really hard to see in the back of your mouth. And this has the highest incidence of being understaged, at least in my experience. So this was an example of a retromolar trigone carcinoma that the surgeons thought was just nice and easy and they can just scoop it right out. But look at the bone right here. See how that bone's eroded right here? You've got to look for that bone erosion because I can tell you numerous times that erosion is underappreciated. So this is my favorite tiger. This is my favorite animal. These are my tiger stripes. So this is an example of a retromolar trigone carcinoma. Now what I want to do is draw a line down the middle, compare the left side to the right side, and now you can learn how to use my tiger stripes. So this area right here is going to be the buccinator muscle. This is going to be the fat right here, and this is the mandible here. Now look at the opposite side. Notice the stripe right here, the stripe is gone, and right here is this tumor involving the retromolar trigone. So it's a little bit anterior and a little bit posteriorly. Now these retromolar trigones, as Dr. Weil mentioned, can grow superiorly all the way up to the hook of the hamulus. Why is that important? Because if the surgeons thought that this tumor was only located right here in the retromolar trigone by itself, well, it's possible if they don't see this superior extent extending up to the pterygoid, they're going to get a positive margin. And how do we determine that? Well, look at my stripes. Draw a line down the middle. Here's the buccinator muscle. Here's a fat plane. Here's the hook of the hamulus. Now look at the right side. See, you see the buccinator muscle a little bit? See the smudginess right here in the fat? See the thickening right here? See the loss of the fat planes adjacent here to the hook of the hamulus? See this gray here? See how it's nice and black here? That's that subtle spread. And that's why I think a lot of these retromolar trigone carcinomas do so badly, because we as radiologists fail to appreciate the full extent of it. This is an obvious case of a retromolar trigone carcinoma that's eroded the ramus of the mandible. See how the fat's gone on the right compared to the left? See the white right here? See this fat right here? See how this is all obliterated? So that was pretty obvious clinically. This, on the other hand, was a retromolar trigone carcinoma. And when we do a T1 weighted image with fat suppression, with gadolinium, see how much this is enhancing compared to the opposite side? Well, I think I was away at a meeting, I hope this is what happened. The surgeons went in, operated on this. They didn't take enough of the mandible out. So they didn't appreciate all of this mandibular involvement. So this patient underwent a segmental mandibulectomy. You'll see the reconstructions tomorrow. They went under a 6-hour procedure to do the reconstructions. And when the final margins came back, it was positive. So the poor patient had to be taken back. They had to take out the flap, do the reconstruction again. So it's hard enough for the surgeon, but can you imagine for that poor patient? So from our standpoint, my take-home message for you is that when you have these tumors that are involving the retromolar trigone, Number one, do a CT scan to look for bone erosion. But number two, and I finally convinced my surgeons to do this, is get MRs on all these patients, make sure you use gadolinium, and take a really, really close look at the bone. Because I'm 100% sure, I shouldn't say 100%, I'm 99.99% sure that, again, one of the reasons patients do so bad is because there's actually tumor in the marrow that's not appreciated on the preoperative study. And the last thing that we'll talk about that Dr. Weil mentioned was squamous cell carcinomas involved in the hard palate. And again, we make such a big difference here because normally when you look at the mucosa of the hard palate, it's just a very, very thin line. So if there's just tumor involving the mucosa, the surgeons can strip it out. And I can tell you, when I see the patients, I do not know whether or not that bone's eroded. But if I say that this tumor right here is eroding the hard palate, then the surgeons have to undergo this, a maxillectomy. And again, if you say in your report the patient's got bone erosion, that's what the patient is going to get. And that's because of you, okay? So just realize how important that is. Now, there are other tumors that can involve the hard palate. Now, as I mentioned before, you can have these minor salivary gland tissues, these minor salivary gland rests. They have a specifically higher likelihood of occurring in the hard palate than just about anywhere else in the head and neck, outside, within the oral cavity, I should say. So as a result, you can have tumors such as pleomorphic adenomas involved in the hard palate, and this is an example of a mucoepidermoid carcinoma. Now, squamous cell carcinomas, what do tumors like again? They like smokers, drinkers, muscles, and nerves, right? And minor salivary gland tumors, especially tumors like adenoid cystic carcinomas, really like to grow along the nerves. I think you're going to hear a talk on perineural invasion later. But as Dr. Weil mentioned, when you look at the posterior lateral aspect of the hard palate, you have these foramen. You have the greater and the lesser palatine foramen. So anytime that I have tumors that are extending back here to the posterior aspect of the hard palate, in my mind, a warning sign goes off. And I've got to figure out whether or not is it possible the tumor could be spreading along that nerve. And if I draw a line down the middle, compare one side to the other side, does anybody see a difference between the white arrow and the yellow arrow? You can see that this is enlarged, right? So this is retrograde perineural spread along the greater palatine nerve. And I can tell you the majority of the time the surgeons do not know that tumor is spreading along the nerve. And as a result, if you don't tell them it's spreading along the nerve, then they're going to do a resection right here of the hard palate. And once they come back, the pathology is going to come back, you've got a positive margin. And they're like, what do you mean I got a positive margin? It's up to us to tell them that nerve is at risk because once these tumors grow along the greater palatine nerve, they're going to be here in my favorite foramen, in my favorite fossa. Does anybody know the name of my favorite fossa? It's between the pterygoid plates and the maxillary sinus. And the palatine bone, pterygopalatine fossa. That's where that nerve is located. So this tumor can grow all the way along these nerves. It can go into the sphenopalatine ganglion, and it continued to grow superiorly and jumps on this nerve. Does anybody know this nerve right here that goes through foramen rotundum? That's V2, exactly right. So in this particular case, another example of a hard palate cancer, draw a line down the middle, compare the right side to the left side, and remember my favorite animal, which was what? The tiger. Someone's paying attention. Who's that? Thank you. That's awesome. Thank you so much. I've got like a wife and 2 kids, and no one ever listens to me. So someone's listening to me here. I had to come halfway around the world, but thank you. So if you look the right side to the left side, notice how there's normal fat right here in the pterygopalatine fossa. And with the leap of faith, you can actually see this little line right here. See this line right here? That's actually V2 in the pterygopalatine fossa. But on this side, notice how all of the fat in the pterygopalatine fossa is completely gone. And if you look real closely, you almost see a claw right here. You see something going posteriorly and right here. So this is V2, and this is the nerve of the Vidian canal. Now, when we look at the coronal T1 post-contrast image, again, draw a line down the middle, compare the right side to the left side. And remember, once these tumors get on V2, they can grow anterior and posterior. So can I convince you there's too much enhancement and enlargement of V2 on the left compared to the right? In fact, with a leap of faith, right at the tip of my arrow, do you almost see something that looks like a target, see something that's gray, and see the enhancement right around it? So that's the normal perineural plexus that's surrounding the nerve. And on the left-hand side, we can see that tumor is enhancing. And for extra credit, because this is my last slide, so I can say that. Does anybody see another nerve that's enhancing right here? Anybody see this compared to that? So this is actually tumor growing along Vidian's nerve as well too. So that's why these tumors can be really, really tricky. And if they continue to grow all the way back, they can actually extend, in this case, into Meckel's cave. So here's normal's Meckel's cave on the right and normal's Meckel cave on the left. So I just went through this detailed anatomy. And the question that you have to ask yourself is, who cares? So what? How do we make a difference? Well, I can tell you, radiologists, we don't get older, right, Dr. Schroff? We get more experienced, right? We don't get older, we get more experienced. So when I trained in the last century. I hate to say that. So I was born in the last century, I trained in the last century. When I started my fellowship, first of all, the surgeons wouldn't believe that we can look at the nerves, actually. And if they saw a tumor that was growing back into the cavernous sinus, the surgeons would go in and actually remove the cavernous sinus. Now, what's the cavernous sinus? The cavernous sinus is the main deep venous drainage of the brain. So they would remove half of the venous drainage of the brain, and then they would remove cranial nerves 3, 4, 6, V1, V2, and the carotid artery. That's what they used to do. And then we as radiologists started saying, yeah, we can see that spread back into the cavernous sinus, so they didn't believe us. But after a while, when they were resecting the skull base and they saw, oh my gosh, the radiologist was right, they can actually see that, they've now started to believe us. So the reason it makes such a big difference is that if we say, at least in the places where I've been to, that there's tumor growing all the way along V2, all the way back into Meckel's cave and cavernous sinus, at most institutions where I've been affiliated with, those patients are not going to be treated with surgery, but they're going to be treated with some type of chemotherapy and radiation therapy. So we have completely shifted the paradigm as to how these patients are treated. So in summary, what we did, and I think I'm right on time, is that we talked about the oropharynx and the oral cavity, and hopefully I was able to give Dr. Weil and add to his talk about some things about squamous cell carcinoma. And as I mentioned before, if you want to, I have about 15 free talks on YouTube. There's the thing, it's at Suresh Mukherji 359. Follow me on X. I've met a couple friends right here that are friends with me on Facebook and LinkedIn. And then if you are interested in our remote fellowship in the fall, there's a QR code. So again, thank you very much for the honor of being here and for your attention.